Good evening, everyone. Thanks very much for coming this evening. For those that don't know me, I'm Ben Wesson and I'm chair of the Health and Adult Social Services Standing Scrutiny panel. So I'd like to welcome everyone this evening. It's a particularly special day today because it is in fact World Social Work Day. So I'd be really grateful if Kerry, you could pass on our thanks as a committee to all of our fantastic social workers at the council that are doing so much excellent work in the community. So as I say, welcome to everybody that's joining both in the room and also online. The meeting is being live streamed on the council's YouTube channel. If I can just remind those that are online just to remain on mute and just to use the raise hand icon if you wish to speak. And I think I can see that so far online we just have Robert, our independent chair of the Safeguarding Adults Board. But Anna-Marie, is there anyone else?
Yeah.
Not yet. Lovely. So before we get into the business of this evening's meeting, I just wanted to notify the panel that I have been, as I know panel members have been approached by the Ealing Reclaim Social Care Action Group and also the Committee for Action in Sheltered Housing, CASH, and some panel members too, about taking questions at this meeting regarding the termination of the council's care line. Under the law, I'm not in a position at this meeting to agree on questions about the care line, as it's not an item that's on our agenda. And I have sought advice from Democratic Services about taking questions under urgent items. I've been advised that it's not possible as the urgent items section of the meeting is only for issues that have become apparent after the agenda has been published. But with that said, I have forwarded the questions from SCAG to Kerry Stevens as the Strategic Director for Adult Social Services for a written response. There will also be an opportunity for SCAG to raise their questions directly with Councillor Blacker as the Cabinet member at tomorrow evening's Health and Wellbeing Board meeting. And I'm also in the process of arranging a briefing for this panel and also for members of SCAG to discuss the care line in more detail shortly. So hopefully panel members are happy with that approach, but I can see Councillor Crawford indicating, so I'll bring you in.
We've had you on the tube, you know, been really useful. I'm very grateful, Chair. You've done some good work. I don't like to see things coming as a matter of urgency when councillors have not received a report, and we're not used to this. I don't know. I gather it's been made an officer's decision, but I would have thought that even whether it be an officer's decision or a politician's decision, a leader's decision, a cabinet member's decision, there should be full accountability, transparency, and there should be a report. Briefings are all very well, but I want to read a report. And also, I may not be available for these meetings. It's not the same. So I would like to request through you, Chair, and with the agreement of the committee, that whatever a full report comes to this committee, and that we ask that any work, and I see there's an April the 1st, deadline, put it on hold. That's my suggestion, because else, what are we having this committee? What is the use of this committee? So thank you for your forbearance, Chair.
Thanks, Councillor Crawford. Obviously, I'm not in a position this evening to comment on pausing the decision, but I know that your comments will be noted, and of course, I'm very happy to request a report on behalf of the panel. That's a perfectly reasonable request, and the panel should have the opportunity to scrutinise these matters. So, thank you. I am going to move on if that's okay, because we have got quite a lengthy agenda this evening. So the first item on the agenda is apologies for absence. I'm not aware of any apologies for absence, but I do have apologies for lateness from Councillor Mataza. Are there any other apologies for absence? No. Number 2 is urgent matters. I have no urgent matters this evening. 3 is matters to be considered in private. There are no matters to be considered in private tonight. Declarations of interest. I'd be grateful if panel members could confirm if they've got any personal or prejudicial interest in any of the matters on the agenda. I should declare that I'm employed by the Nursing and Midwifery Council, and I'm looking at Councillor Conti, who I know will want to declare his interest.
Yeah, I'm a GP in North West London.
Lovely. And I know that we have apologies for lateness from Councillor Mataza, but I'm sure he will declare his interest when he arrives. The next item on the agenda are the minutes of the last meeting. Can I ask panel members to review the minutes to agree them for accuracy? Do I have agreement? Thank you. The next item on the agenda is item 6, which is the panel's work programme. We're being asked tonight to review and agree the work programme. I just wanted to draw members' attention to the visit that's been arranged. I'm really looking forward to this, to the sexual health service at Mattock Lane Health Centre. It's from 2 till 3:30 p.m. on Thursday, the 25th of April. And the purpose of that meeting is to support the scrutiny work that we will be doing during our May meeting. Could I ask, just for logistics and planning purposes, if you would like to join and you haven't confirmed your attendance, that you just do so, and if you could just make Anna Marie aware of that, that would be super. I'm also aware that there is soon to be an exciting opening of the Community Eye Care Diagnostic Centre hub in Willesden, and I'm hoping that we can arrange a visit for members to that as well, again to support with May's scrutiny work, where we'll be discussing ophthalmology. So those are the things that I wanted to raise. I would also like to just welcome David, who is here this evening, David Curley, who is representing Carleen Duffy. And I know that you had some specific requests for information around dentistry ahead of the May meeting.
Yes, thank you, Councillor, and I want to thank everyone here tonight for having me. My name is David Crawley. I'm the Project Officer for Health Watch Ealing. Given that the next scrutiny meeting will have a section on dentistry, we wanted to pose some questions that are of great import to patients in the borough from things that we've noticed in our patient experience program. How are we sharing information with residents on which dental practice is accepting new patients? We as a Health Watch are more than happy to signpost and give information to residents regarding this. How are our dental contract locations impacting residents? Are we ensuring we have NHS dental contracts in the most economically deprived areas of the borough? How are dentists ensuring residents know about available payment plans so they are not reluctant to seek care due to any financial impact? How are we, as a community and community team, sharing knowledge in schools with young people about the importance of taking care of their teeth? Are we visiting schools with dental supplies, sample packs, and information booklets? And that was the questions that we had, and I want to thank you all again.
Thanks very much, David. And I can see that Neha is busy scribbling those questions down. We will also share them with you, Neha, so that we can get those as part of the report that you'll be providing at the next meeting. But thanks, David, for raising those. Any other items for discussion on the work programme? Councillor Crawford.
If I could just add, I'd be interested if your scoping report, older people who are isolating, accessing a dentist, and how they basically what support services that there are to get them there and from, because they might be in, some discomfort. Thank you.
No problem at all. I'm sure we can cover that as part of the report too. So thank you very much. Are we agreed in terms of the work programme? Excellent, thanks. Councillor Mataza, you're very welcome. I just wanted to invite you to declare your interest in terms of your employment. If you just want to use that microphone.
I'm a general practitioner within the Ealing Borough, and I represent 2 PCNs as well.
Lovely, thanks very much. Grant, in which case we'll move on to item 7 of the agenda. This item is about primary care in North West London and same-day access to GP primary care. Before I invite Linnell, Dr. Taylor and Neha to introduce this item, I just want to provide some background information for panel members. I requested that the NHS same-day access proposals be added to the HASP meeting agenda so that the panel could be updated on the Integrated Care Board's plans. We only have a short time to consider this matter due to the full agenda that we have this evening, but I felt that it was really important for our panel to be involved. The item was discussed at the North West London Joint Health Overview and Scrutiny Committee last week, which brings together the 9 boroughs which make up the North West London area. And as chair of this committee, I sit as a member of that committee as well. Many patients, members of the public and GPs expressed concerns about the proposal, which would see patients not being able to make a GP appointment via their GP practice, but having to contact a separate hub. And the ICB had not engaged with the JOSC prior to releasing its plan for implementation in April. The chief executive of the ICB apologised for both the poor timing and the communications issues at last week's meeting. We had a very lengthy discussion, as I'm sure Dr. Taylor will agree, at the meeting, and we came to some what I thought were really important recommendations for moving forward. We support the ICB in delaying the implementation of proposals for 1 financial year. We wanted equalities impact assessments and human rights impact assessments to be undertaken before the proposals were implemented, not afterwards. We felt that there should be meaningful consultations with patients, the public and GPs, and that feedback and evaluation data should be provided from the pilot sites. We also felt there should be adequate measures developed regarding safety and effectiveness. And NHS colleagues at the meeting agreed that they would take forward these recommendations and then engage with the JOSC before bringing back further plans. The other thing that I would just like to remind members is we are now officially in the pre-election period for the Mayor of London and the London Assembly members. So I don't want to teach anyone to suck eggs here, but please just be particularly alert to not making party political points. Not that I would expect such comments to be prevalent in a scrutiny panel meeting anyway. So I'm going to invite Linnell, the lead for Access and Primary Care Strategy, who will update us on the ICB's plans, and also invite VJ and Neha to give comments. After that, we'll also hear from representatives who I'll introduce from Ealing's local medical committee as well. But Linnell and colleagues, can I pass over to you in the first instance, please?
Thank you. So we thought it would be best if I started off with just some history about what we have been doing over the last few years in Ealing in particular. The committee will remember we have brought previous papers on general practice, access and general practice overall, the workforce pressures, the changing nature of how general practice operates a couple of times actually. So the first one was November 22 and then September 23 with a further update. In there, we described how since COVID, the pressures on general practice have been really increasing. And we can see from the data that we've got that general practice is delivering even more appointments than ever before in Northwest London. And it is really important. And even though they're delivering all of these appointments, and a lot of them, about 70% nearly, are face-to-face, there are still the patient's needs aren't being met, and we still get concerns from our residents through the GP survey, through Health Watch, about being able to access general practice in a timely way. So this has been a continuous improvement cycle that Ealing, and in particular, has been working on since 2017, where we first started working on access in general practice. And this is the evolution of that for us. And we're really, really keen to work with our general practice colleagues as well as our local residents to get the model right that works for our population. And I'm going to hand over to VJ.
I'm not going to spend too much time, so I give the opportunity for questions. But the main thing I wanted to say is this journey that we've been going through regards to access has been going on for some time, as Neha says, and last summer we really wanted to look at what we can do across Northwest London in terms of a Northwest London access program involving our PCNs in Northwest London, and hence we asked for expression of interest for those Wave 1 early adopters to look at how they can work collaboratively in terms of the issue around access. And we know for some time now that our residents have been asking us to consider and review how access is delivered in Northwest London. And so we did develop those 5 key objectives for Northwest London around access. One is in terms of improving the patient experience, and there's been lots of feedback around patient experience. Secondly, it was around ensuring that those that require a same-day appointment is able to get a same-day appointment. Those that require a routine appointment within a planned 2 to 4 week window, they're able to get that. Ensuring that our workforce in primary care and general practice are able to work and manage within the pressures that are in general practice. And then finally, to make general practice a happy environment for the workforce to continue to work, to ensure that we've got recruitment and sustainability and resilience. And that was our key objective in Northwest London. And hence we started to work with our Wave 1 early adopters to develop programs of how we can look at access collectively. And once they were in a position to start to then implement those, as it's mentioned in the overview paper, they started to implement and deliver those. And that started in the late 2023 and early 2024. And they continue to evolve and iterate how they are trying to deliver access at scale. And hence, as Councillor Weston has said, in terms of the evaluation of what they're trying to do at the moment, it's still very early in terms of what they've done. However, some of the early feedback we are getting is that it has enabled those PCNs, and particularly those clinicians within the PCN, to spend more time on those individuals with long-term conditions in complex care, because that low complexity work is being centralized in a way which is efficient for those individual PCNs to be able to deliver that type of care in a way which is effective, safe, and done in a way that allows the rest of the primary care workforce to concentrate on the more complex needs of their other complex nature in terms of the populations that they serve. I just want to finally say that from the 1st of April, there will be no changes in terms of how individuals in North West London access their GP. It will continue as it is today. It will continue as it was last week, last month, last year. They'll still be able to access their GP as they do currently. What we want to do going forward is to work with our remaining PCNs, our remaining 35 PCNs, in terms of looking at how we can have a quality improvement approach in terms of how they can start to consider how we collectively look at the access issue in North West London and come up with some co-design, co-production ways to improve the access, but making sure that we do bring our population and our patients along that journey as we try and develop it over the next 12 months.
Thanks. Linnell, did you want to add anything to that?
Thank you. Look, really just to add that was never a approach that patients would be sent somewhere else. I mean, the whole concept behind this is providing options and choice. And I think that's really important to note. I think sometimes the messaging have got confused, but actually, really, this is actually working with the workforce that we've got in the best way that we can, and providing options to enable that, you know, people can see somebody when they need to, just as we already do with extended after hours services and things. So I think it's really important to note that. Thanks.
Thank you very much. And I know that panel members will be thinking about questions to ask, but before I invite questions from panel members, we're really grateful that we have Dr. Sukhpal Shergill, Dr. Sid Datta, and Dr. Mark Mikhael from Ealing's Local Medical Committee. I'm going to invite you to provide some comments, and then we'll open it up to panel members for questions.
Thank you, and good evening, everyone. Thank you, Councillor. I'll start off with what's happened up to now. My colleagues will talk a little bit about the current position and perhaps then moving forward to the future. I don't think there's a single GP who would be upset with the concept of quality improvement known as QI. We do it every day. QI is something that underpins all practice. We're interested in making improvements on every area of medical practice. The way that this consultation has taken place is something that we haven't really experienced before, and I think that the overall majority of GPs have felt that the fundamentals of QI have been missing. The evaluation of the pilot program, the cherry picking of the evaluation of the pilot program is something which really needs to be highlighted, because what we hear from the pilot areas, there's a lot of concern about what was being suggested as a way forward. And in the course of 6 weeks, the whole GP community has rallied round and indicated their displeasure as to what was being suggested. And actually where we've got to, which mirrors the national picture in terms of continuity and in terms of non-doctors seeing undifferentiated conditions, has been proven to be an absolute fundamental reason why the project that was being proposed should have been not implemented the way it was. I'll pass over to my colleague to talk a little bit about where we are with our current access in Ealing.
Thank you, Councillor, for inviting us here today and to provide some comment as well. Just want to follow on from what my colleague has said about the consultation process. At the moment, we welcome the fact that the local ICB has heard some of the feedback, both from patient groups, from us as GPs, and I'm glad to see that actually there's been some pause for reflection, possibly throughout the following financial year. I think there's still some concerns because at the moment, the indication is that nothing's going to change, but nonetheless, we're hearing that potentially there's funding that normally goes to GPs that's been part of the Ealing standard is going to be withdrawn in 10 days' time, and that will have impact on service delivery and access as well. So the enhanced access service that was commissioned as part of the Ealing standard will no longer be present. So I think not only has there been essentially a pause in terms of access measures, there's potentially steps going backwards with regards to access that we're all very concerned about. And again, I think after COVID, we recognize that obviously there's quite a lot of demand out there, and I think we'd be happy to work with the ICB to try and come up with good solutions. But I think there's been an overwhelming concern with regards to the model and its safety, really.
Thank you, Councillor. I just not in order to not repeat what my colleagues have said. So I'll just reiterate the point that I think we welcome that things have been paused for reconsideration in 2025. The current concern is that what the term cliff edge, which was mentioned in the previous meeting, still somewhat is present because practices are in a position where they feel that access funding is going to be reduced post-April. They are now thinking about how that's going to work. Prices and costs have gone up for practices, as is the case nationally elsewhere across other sectors. And now we're in a position where we're thinking or we're hearing that we may be across the borough losing £1 million that goes to primary care for access. Now £1 million can add up to roughly about 3 to 5 nurses per PCN. So if you calculate how much access that can reduce, the public, will understand that that's a significant amount of access. I think going forward, what we need to hear is what is going to happen in 12 days' time for colleagues to feel ready for the proposals, whether they're being postponed or not. And I think the working with Ealing Local Medical Committee would be, which has been the case historically, just to feedback what the patient feeling is from practices on the ground, and making a plan going forward. The other concern is currently the practices are actually, we've canvassed some practices, and 90 to 100% intend to reduce access if this funding is cut. So this is going to have the opposite effect, and the cliff edge is still there, very much so.
Thanks to London Medical Committee colleagues for those comments. Opening it up to panel members for questions now. We've got about 20 minutes for questions, but I have also got questions from members of the public that I have accepted as well, so we need to fit those in. So if I could ask for concise questions and concise answers as well, that would be lovely. Councillor Conti, and then Councillor Cook, and then Councillor Mataza. I'll take those three.
Thank you. I guess it'd be interesting to hear actually from the ICB about the cliff edge of funding, and actually if this isn't going forward in April, so what is happening to that funding? Is there going to be funding that is reduced, as the LMC have said? And if so, what do you envisage the impact of that going to be? I guess the questions that I had were, one sort of feeds on from the discussion we had at the last meeting about the use of the word clinicians and who patients are going to see. I think it isn't clear necessarily in the document that was provided. The word clinician is used a lot, but actually who are patients going to see? They talk about GP supervision, but is that one GP in a hub supervising multiple members, of a multidisciplinary team? How are patients going to be ensured that they're seeing the right person? And how are patients going to be informed that so they know who they're seeing? Because I think, as we brought up last time, that often patients think they go to a GP practice or a hub or wherever they're going, they're seeing a doctor and potentially they're seeing someone with 18 months worth of training. So how do we ensure that it's safe? And how do we ensure that patients are empowered to know who they're seeing? And I think this applies both in a primary care setting and in a hub, wherever that's going to be. The other thing with hubs is, what's the envisaged distance, that an average patient will have to travel to go to a hub? Because clearly, they're going to have to travel further than they would for their normal general practice. And so, what is envisaged to be the average distance? If a patient, for example, is frail, elderly, etc., how are they necessarily going to get there? I understand the issue about that people will be diverted to different places, but it's just, it's going to clearly make it more difficult, to some elements, make it more difficult for some patients potentially to access primary care. I had a few other questions, but I'll leave it there because I know we're pushed for time.
No problem. I'll try and come back to you. Mr. Cook.
Thank you. How does this proposal avoid crossover or duplication with parts of the 111 service? Thank you.
And then Councillor Mataza, please.
Can you hear me? Okay. Thank you, Councillor Hassan. I echo some of the things which my colleague, Dr. Conte, has said. The demand on the general practice access has increased, and I can tell you that there are certain reasons. One is backlog of the pandemic, and then majority of the services and from the hospital are being sent back to the general practice. And also with the current cost of living crisis and international and global political situations, mental health has deteriorated, and that has increased the demand on the general practice. Now, that has a backlash on the workforce working in Ealing and around areas around Ealing. If we reduce funding, which is already existing within the general practice, how we are going to increase the capacity to meet this demand of access? Thank you.
Thanks very much for that question. NHS colleagues, I'll pass to you.
So I'll take a couple of the questions in particular around the contractual question about the funding. So we, as an ICB, as a CCG at the time, put in additional funding into general practice, which not other boroughs received. It was only Ealing that received that, particularly to try and improve access at that point. Now the access is about the same as all other boroughs, and the other boroughs aren't receiving that additional funding. So what we're proposing is to reutilize this same funding, which is still available in the contract to practices, but just as a separate contract, because that was the ask of everybody to separate this. But in order to do this quality improvement work. So if practices engage and PCNs engage with the quality improvement work, they would absolutely get the full amount of funding. And we've continued to push to ensure that that funding is always available for Ealing general practice. The other thing I would say is we are really, really keen, and we've reached out to our clinical directors a couple of times and tried to arrange meetings to have these very open conversations and to discuss the way forward. So I would just say that we're really open to having these conversations.
I'll just pick up on the other question. So the question around the hubs, I think there has been some misunderstanding around the terminology of hubs. What we're trying to describe here is a concept rather than a physical hub or a virtual hub. We do use that word in different ways, and this is really about how you can centralize some of the activity in a way which is efficient, rather than physically having a bricks and mortar type of situation where patients will need to be seen. I think what's important to understand is that in terms of how the primary care workforce has changed over a number of years, particularly in relation to the expansion of ARS roles. We have a wider workforce which works collectively in terms of managing the needs of our population. That includes not only the same-day demand, but also the demand on long-term diseases and complex care. So it's important to understand that the clinical effectiveness in terms of how you manage your needs of the population, you do that in a team approach, which is much more collaborative than only your GP. The situation where your GP managed all your needs has changed. You know, that is how the reality of how we work in general practice now. You have to work in a collaborative way in terms of ensuring that it's whatever model the PCNs decide to deliver, it needs to be clinically safe. So it's for the PCNs themselves to determine how they want to work collectively to manage the access and to ensure that they've got the right skill mix or the workforce to do it and the correct competencies. We are not providing a blueprint for them to then work on. They have to self-determine how they want to do that and work collectively, and hence the quality improvement approach is the right approach, so that it's a bottom-up approach in terms of how the PCNs with their populations, with their PPG, try to consider in relation to the workforce that they currently have and the workforce in the future that they may have, to how they can deliver access in a collaborative, collegiate way to support the needs of the population that they serve. The question around the 111, so we know that 111 works 24/7, and general practice is supporting 111. We provide slots at each individual practice, which is 1 slot per 3,000. That is a GMS contract requirement that will continue as before. What we tried to say in terms of the documentation is that can all those collective practices within that PCN aggregate up all that capacity that they have to provide for 111 in a way that works efficiently for them to do that collectively rather than at an individual practice level. And then the last question around another one around the clinical safety. I'm a GP in Acton. I'm just as concerned about clinical safety and how we provide care for our patients. And there was no way where we were trying to compromise how we deliver care for any of our residents in North West London, and particularly in reference to Ealing. This was really about looking at how we can do it in a way that is effective, that supports collaborative working, and ensuring that we're able to work in a way that is upskills the workforce that we currently have. We all know that the GP workforce is a precious commodity. We are trying to expand that workforce. The GP workforce in North West London, we have the lowest per whole-time equivalent per head of the population across London. So it's important that the workforce we currently have, we maintain that workforce, but we try and build on that workforce using the GP as a centre point for all the other workforce that we have in general practice to work in a supported and collective way.
Lynelle, did you want to add anything to that? No, okay. I'm looking to Councillor Conti, Mr. Cook, and Councillor Matarzat just to see if there's any follow-ups. Councillor Conti.
Sorry, a couple of follow-ups. I guess, Neha, it was just on sort of that funding that linked with further quality improvement work. I guess a bit more about what that entails and what's expected for practices, and if that money at the moment is being used solely for enhanced access, is that what it's? No, it's not. That's not that extra £1 million that you're talking about. Is that what's that been allocated for now? Because if that was purely for access and now it's additional projects going to be needed to be done to get that money, then how's that all going to marry up to ensure that access is in the short term isn't reduced? And then it was just back to, I understand what you were saying about it's not a physical hub that someone's going to have to go to, but clearly if you're pooling services across a PCN, people are going to have to travel further to access, whether it's to a different GP practice already there rather than a new building. So there is going to be increased distance, because otherwise if everyone was just accessing it at the same primary care, then there's no point of this scheme in the first place. So clearly there is going to be additional travel time for patients potentially, and PCNs could potentially cover a relatively largish area, which people can have to maybe take additional public transport, etc., to access. So I think, you know, I don't think that should be dismissed if there's, given that it's not a physical new building. I think those travel implications are still there. And I do think I understand the nature of how general practice and primary care operates has changed in the terms of a much wider multidisciplinary team. Now, you know, that you know, just because things are moving forward doesn't necessarily mean that, you know, it's right, you know, how things are evolving and whether things need to change, and, you know, how sort of safety elements. I know just, I think it was last week that the Royal College of Physicians have had concerns expressed about health sort of physicians associates, etc., and the safety of their use in hospitals. So I still, you know, I don't think you articulated clear enough how that safety element is going to be ensured when it's through the scheme. It sounds like there's going to be an even greater use of extended of other members of the multidisciplinary team. Not to say they're not valued, but when they're seeing undifferentiated patients, that is a real big concern. And I don't think I didn't feel reassured by necessarily what you were saying, that safety piece in terms of, you know, a GP, how many additional people are they going to have to be supervising? What is the makeup of that? I think we need that additional information to provide extra reassurance.
Mr. Cook or Councillor Mataza, any follow-ups from? No. Okay, so we'll deal with those follow-ups and then I'll bring Councillor Crawford in, who's been waiting very patiently. No, I'll take your responses to the follow-ups and then bring Councillor Crawford in.
Okay, so the first question was around. I'm going to go back to the clinical safety. You're absolutely right, Councillor Conte. It's important that clinical safety isn't compromised. You know, what has changed in general practice is that everything doesn't start and end with the GP. You know that, and I know that, in terms of how the multidisciplinary team is working effectively. What has changed is that the skill mix has also changed. We have paramedics working in general practice. We have advanced nurse practitioners working in general practice who have the skills and competency to manage those low complexity same day activity. They've been doing that prior to this program, and they will continue to do that. It really ultimately depends on how the PCN looks at their workforce, looks at how they map their workforce that they currently have, and the competency and skill mix for them to use those individuals in a way that they are providing care at the top of their license, but also they are supported and have the supervision for them to be able to do that. That bit is absolutely paramount, and it's up to the PCN to determine how to do that. Some of the PCNs may decide, as they start to collaborate, looking at how they can work effectively in terms of managing same day demand, may decide that a GP model is the best model for them. But it's for the PCN to decide. We're not specifying a particular model. We haven't specified a particular blueprint going forward. This is why the quality improvement work is so important for 24-25. As each PCN starts to tackle and understand how they can manage the access issue. And this, I go back to what I said right at the beginning, you know, for a number of years now, the feedback from the general public and the patients and population groups is that, you know, there is unhappiness about access in general practice. You know, we've been doing stuff in Northwest London that NHS England have only decided to do this year. The cloud-based telephony investment we put in Northwest London were the first across the country. Then NHS England came along and decided to invest that for all of the practices in England. So we've been trying to do things, you know, to really improve how we manage the access agenda in Northwest London, and we will continue to do that. But I take the comments around our initial approach. In hindsight, with all the feedback, all the reflections that we had, wasn't the right approach, and hence it's important that we have a collaborative, co-production, co-design approach with the PCNs, with the populations that they serve, and other relevant stakeholders to try and get a model which is right and bespoke for that PCN. That is really the last measure around that. And then finally, in terms of the funding that you mentioned, the total funding for the enhanced services in Ealing is not going to change. It will remain the same. What we've had previously in Ealing is we've had a suite of enhanced services. Some of them were right across Northwest London. Some of them were bespoke to Ealing. One of those services was an access specification which we developed prior to the COVID pandemic. Over time, we have realized that that specification, whether it was going to continue or not, was no longer fit for purpose. The way individuals access primary care and general practice is different post-pandemic to pre-pandemic. And so it was important to understand that irrespective of whether we had a Northwest London access specification, if we did continue to have an individual Ealing specification, that would have changed. What we're trying to do is to get some level of
Bring
investment
the
right
comments
across
to a conclusion.
Northwest
Thank-
London. So just more importantly is that if you look at the GPAD data in terms of individual PCNs right across Northwest London, yes, the Ealing PCNs are in the upper quartile, but they're certainly not providing the most access compared to all the other PCNs in Northwest London. And so we need to look at what we had before, what we're going to try and do in the future. Yes, there may be a possibility that some level of access might drop in this interim period over the next 12 months as the PCNs develop that quality improvement. But if they can implement that quality improvement in year, then the expectation is that they will try and have some more efficiencies in terms of how to deliver that access.
Thank you very much. I'm sure that Councillor Conti would wish to come back on some of those points, but I'm going to bring in Councillor Crawford. I'm then going to take David, our Health Watch representative, and then Councillor Nagpal, and I will take Councillor Steed at the end, and that will be the round of questions. So, Councillor Crawford.
Thank you. You've touched on some of the questions I was going to ask, which was what is your team, making the most of the team, and I'm as a patient, I'd want to see a doctor. I went to I had a checkup with a nurse some months ago. I mentioned something. Oh, it's fine. Doesn't happen. Next time I was seeing a doctor, I had the blue light treatment on that very issue. I was absolutely devastating, and I was at hospital with it it was really considered quite serious. So people of my age and that vulnerability and that frustration of not seeing a doctor. So I in future would not actually, I would actually insist on seeing a doctor at that practice now, or otherwise I would move to a smaller practice, which I think could actually see me. I have real concerns about in where the ward I serve, North Acton, East Acton area, buses don't go. It's very difficult to cut across and find, and certainly on the other side of the Western Avenue, it's difficult and very few GPs. So referring, and there's a much older community there. I think there are going to be serious issues, so I would be concerned. So my question actually is, again, you touched on, was you talked about patients, co-designing the same-day access hubs with the patients. Now, these the patient groups actually quite often they're not well attended. But tell me what you've done leading up to this.
Thank you, Councillor Crawford. David, over to you.
Thank you. I can definitely see the benefits of the system, giving patients more options for same-day care, while at the same time alleviating pressure on the system as a whole. One concern that we've seen from our patient experience reports is regarding communication between GP practices, hospitals, and different health services. I just want to see how we can ensure that if they do go to a completely different building for the same day hub, how can we ensure that communication between them and their normal GP is good, prompt, and proper?
Thank you, Councillor Nagpal.
Hi, thank you. I want to know to what extent GPs across North West London have been consulted on this. So we've got a sample of GPs here, all seem to have concerns about it. Is that the general consensus that you've seen with the consultation that has happened so far? And if so, how will you address their concerns? And will there be another round of consultation thereafter, or is this ready now for delivery?
So there's a thread there through those questions around consultation. I'll bring Councillor Steed in, and then we'll come to you, Vijay and colleagues.
Yeah, very quickly. Very quickly, has this model been tried anywhere else in the UK up till now? And if so, what may be the results, if there is any results? And secondly, just a general observation, it would be really helpful, I think, to the committee if we actually had some feedback from those GPs in the Norfolk PCN. Yeah. I don't know if we can somehow arrange that, but it would be good.
Thank you very much. I'll come to you.
So I'll go back to your point around the public and patient engagement. Yes, you're absolutely right that we hadn't got the public and patient engagement right when we started to develop it in this program. And as we said in the joint scrutiny last week, we have listened, we have learnt from that. We are going to develop a North West London engagement program in terms of engaging the public. We also want to do it at a borough level and also at a PCN level, and that's going to be really important to ensure that we're hearing everyone's views, we are hearing everyone's feedback, and we're able to then influence that co-production and that co-design at a local PCN level. That is the approach that we are going to be undertaking. As part of the quality improvement, there are a number of strands of that quality improvement. One of those strands is around the PCNs understanding what their current same-day demand is. And that can be quite complex to work that out because of the way individual practices manage their access on a day-to-day basis. But you need to be able to do some kind of baselining at an individual PCN level to understand your demand. So that's going to be really, really important. Secondly, in terms of having a good understanding about your workforce skill mix and competency, as I've mentioned, it's also important to understand what the current patient experience is regarding within your PCN, and using that patient experience as a springboard in terms of what you want to do going forward in terms of that quality improvement. That's going to be really important. And then finally, looking at how your current channels of access within your PCN, within your practice, because there is a lot of variability. A lot of patients in some practices prefer a telephone method of access. Some prefer the online consultation. Others may decide to walk into the practice. So it's important that the PCN looks at how those channels of access are currently working and what they can do to try and improve that, and making sure that the whole breadth of the population has that equal opportunity to access as part of that quality improvement work. So that's really important going forward. With respect to the ongoing consultation, it's important that that consultation or that engagement, rather than consultation, continues to happen at a borough and at a local PCN level as the PCN start to develop that quality improvement approach in terms of how to look at access going forward.
Neha, yeah.
Yeah. Can I just add to that? I think there's some really important points that have come out of all of the conversations today, and we are here listening, and we want to take all of this on board and make sure that it's influencing how we do this going forward. But what I would say, Councillor Crawford, is just like we spoke last time we talked about access, this is not done in isolation from everything else. We have to, in parallel, address the workforce plans. We have to look at our estates. We have to look at our digital solutions and how that could work, and how we support our workforce to feel like they have got a good quality of work, and we retain some really fantastic people within Ealing and attract more and more to come to work in Ealing. So this can't be done in isolation. We have to do the workforce planning in parallel.
Thanks very much. Looking to colleagues in case there are any follow-up questions. Councillor Mataza, very quickly, and then I'm keen to bring our members of the public in.
I forego for the member of the public. I just wanted to answer Councillor Steed's point that I was one of the member of the Northolt PCN. So we have made recommendations. We definitely, it can work, it is doable, but there are so many issues with it. As Neha mentioned, there's a digital issue, there's a state issue, there's a workforce issue, and there's a shortage of funding issues. If these are met, then this is a doable project.
Thanks very much. And I think we'll be returning to that theme in the recommendations. So our members of the public have been waiting very patiently. And I think the crucial bit of the conversation that's been missing so far has been around patient voice. So could I invite Martin, Sarah and Eve to come to my right, the left, and ask their questions. And if we could start with Martin first. And if you could just use the microphone, that would be grand. Just so that you can be heard online as well.
Yes, the question I raised was the question of continuity of care, because it does seem that if patients are being referred to hubs, whatever kind of a hub it might be, and I was quite interested to hear of a hub that's conceptual and not physical, goodness knows what that might be, then continuity of care is going to be difficult to achieve, to put it mildly. And so that was the concern I raised. And I have a concern about how these questions are going to be taken forward when, despite, and I don't doubt you, Dr. Taylor, but at the Northwest London joint scrutiny committee, I clearly heard Dr. Small say there would be no consultation and no engagement at the Northwest London level, and it would only be at the PCN level. Now, we need to be a bit clear on this, because not only for the question of continuity of care, which is a particular concern of mine, but in general, what is this consultation going to be? Especially as I'll stop now. The pilots, we think of them as pilots. They said, "Oh, they're not pilots; they're early adopters." That was the term they wanted to use at the Northwest London, and that is also a concern. So I believe Councillor Weston is going to take this issue up in writing with Genevieve Small. Thank you.
Thanks very much, Martin. I'll come to Sarah next.
Could I go next, actually? Because in a sense, our questions don't really.
Eve, yeah, happy for you to go next.
I'm kind of following on from Martin. Thank you.
Fine, no problem.
So for people who don't know us, we're actually from Ealing Save Our NHS. We are the main campaign in this area, and I think we do speak for many people in this borough, and in terms of their feelings about what's happening to our NHS. The panel, I don't know if the panel is aware, I hope you are aware of the huge public concern that has been generated about the planned changes to our GP services. And over 13,000 people in just a week signed a petition very much opposing the plans for same-day access hubs. And I've never seen a petition fill that quickly in about 5 days. And obviously we could potentially, if more people knew about it, I think the petition would be probably 5 times that. And I think it's a reflection of the fact that the public are really concerned about who they see. And I really want to echo what Kate Crawford has said, is no disrespect to the other healthcare professionals. They do indeed have a role,
But if I go into the GP, which I did recently, with a really serious chest problem and was told I ought to see a social prescriber, and then a week later I was worse and I actually went to see the GP, and they told me immediately to go to, they thought I had pneumonia, which I did, and I ended up at the A&E. Now, that is not a situation that we want to see reflected across the whole of North West London, which is why my first question is that really, both GPs have expressed, many GPs, not just the GPs here, but across the whole of North West London, have expressed their concerns about what is fundamentally undermining our relationship with GPs. You're taking away that vital relationship, that long-term understanding of who we are, of our families, on all those issues, which don't easily just present with you might go in with a cough, but the GP knows that there are much wider questions, and you could be overlooking really serious issues, which to an untrained eye, and I mean an untrained eye, like a physician's associate with 2 years medical training, who now appear to be gradually replacing GPs, we could be in a situation where a member of the public who doesn't know they're seeing a physician associate goes in with a problem which appears to be low complexity, but actually has a much wider issues that are being posed that are quite serious. These are the kinds of things that the public really do understand. We are not stupid. We do actually understand those issues, and nobody's misrepresented anything. And I'm rather disappointed by the gentleman from Health Watch who just said, well, we seem to support that. I think you should go back and actually talk to people that you survey. I think if they actually understood what these hub proposals are, they certainly wouldn't be supporting them. But my first question is, from what we understand, triage will be mostly carried out by clinicians that are not doctors, and members of the public don't understand that a clinician doesn't necessarily mean a medical practitioner. It could be a physician associate, a community pharmacist, an advanced nurse practitioner. They aren't there, as everybody has said. That's not their job to do diagnosis and work out treatment. Their job is to help to manage that, and that's what they should be doing as part of the team. So how on earth can you justify doing that in the face of all the opposition and all the very valid points that have been done? That's my first question.
And your second question.
And my second question is, can you explain why such a fundamental change to our GP services has not been the subject of a proper public consultation? As far as we're concerned, this is a fundamental change. There should have been a proper public consultation. It's very late in the day to come to the public, and forgive me if we don't feel reassured that there will be a meaningful public consultation going forward.
Thank you, Eve, and I will invite Sarah to ask her question as well.
That one, yeah. Thank you. Hi, I'm Sarah. We're all patients. Everyone around this table at some point in their life is going to be a patient. And I expect you three, sooner or later, or your family is going to phone up and want to see a doctor, right? You might. Okay, so this is a problem we all share. It's not something you're telling us that we have to put up with. We all share this problem. So we all want an access to a GP. For the moment, the problem, Vijay has said this, that we have the lowest level number of GPs per head of population. What have you been doing about it all these years? This hasn't suddenly happened overnight. So you've been looking after GPs. What have you been doing about this? So for me, the most core problem is more GPs. That's what we need in the area. Secondary people are not unimportant, but we need more GPs. What I don't understand is why the £521.3 million for transformation is not going to be spent on GPs. I see there's just 2.1 million is spent on international GP recruitment. What we need is more GPs. I want to know what you're doing about it. Whether you're contesting that you can't spend this money on GPs, because I don't see why you can't stand up and say we need GPs. That's what this transformation for primary care, the transformation is first and foremost more GPs. That's what we need in this area. So that's my question. What are you doing about it?
Thank you very much to our Ealing Save Our NHS colleagues for the questions. I'll invite responses now from Neha, Vijay and Linnell Could I just ask Sarah for you to turn off that microphone, please? Thank you.
Okay, so we've received the questions in advance, so thank you very much. I will start with the last one around GPs. So the funding you're talking about is the 521.3 million that is centrally held for improving access monies for ARRS, which is Additional Roles Reimbursement Scheme. That's a national program, a national scheme, and it has a very clear intention to increase the overall workforce in general practice, recognizing that GPs work as part of that multidisciplinary team. ARRS funding is very specific to ARRS roles such as clinical pharmacists, paramedics, physiotherapists, as well as others, which I've presented in our scrutiny papers in the past. The national program is focused on roles of which GPs are not a part of at this point, and it is a national program. It is clear that ARRS roles support general practice to deliver increased primary care access, increased sustainability and resilience. Given what you've quite rightly said, we don't have a huge pipeline of GPs also coming through to work within Ealing, which is why I reiterate the fact that we need to have a proper workforce plan alongside this program. And for Ealing, actually, we've managed to increase the number of ARRS roles over the last year, and that's been led by the primary care networks to say which roles are going to work for their population and support the GP practices to deliver a better resilient care. I'll go back to the continuity of care question. Continuity of care is an essential component of general practice, which we absolutely recognise. And this is now delivered, as Dr. Taylor was describing, by wider primary care workforce, especially for individuals with chronic diseases and complex care needs. GPs continue to oversee continuity of care. However, this is typically not carried out by a single GP, but a collective multidisciplinary team. Not every patient contract will require continuity care, and there are a significant proportion of same-day activity which is completed in a single consultation. This is the model that happens now in general practice because there just aren't enough GPs now across the whole country. It's not just an Ealing or a North West London issue. And with the increasing pressures, general practice has had to adapt to how it delivers the triage element to enable the demand to be met as well. And this may include, for example, using advanced practitioners or paramedics, as Dr. Taylor's described previously, but they need to have the right competency and overseen by the overall general practice team and skills to undertake a safe clinical assessment. The whole program is about trying to release the capacity to strengthen the continuity of care for patients where needed. That's what this whole program is about. The Northwest, one of the questions about the petition and the non-doctors and how can we justify this program, absolutely hear what everybody is saying. We're not imposing a top-down solution for this. It's not a one-size-fits-all, and that's why that engagement at a PCN level, and every primary care network and every part of North West London will have a slightly different composition and different needs for their population. So it's really important that we hear that local voice as well. And we've heard from the patients and GPs who are worried that everything was going to change in April. And that's not the case. We'll be working with patients and GPs over the next year, and we're keen to hear their ideas for improving access to primary care, which is the issue our patients and residents most often raised with us over the last however many years. Our aim is to develop plans gradually and improve access in each area. It's about improving access in each area. Our priority is that patients have timely access to high quality care. Whatever proposals are developed, all clinical decisions will continue to be made by clinicians. Patients who need to see their GP will continue to do so. Absolutely hear the question about physician associates as well. And I know there's a lot of work happening nationally about that as well. And the final question around the public consultation, because we haven't got one model to describe, it's very difficult to do a whole system consultation. That is just not possible to have a whole system approach because it is going to be tailored to each area. So at a local level, we will make sure that we're working with our primary care networks and supporting them to engage with their local population in order to co-design the solutions that work locally. And we can absolutely bring progress reports back to this committee in the future.
Thank you very much, Neha, and thanks to the members of the public for the questions. We are about 20 minutes behind our agenda now, and whilst I would love to invite follow-ups, unfortunately we haven't got time on this occasion. But can I just summarise and say, in terms of recommendations from this committee, I would ask that we endorse the recommendations that were made at JOSC last week in terms of ensuring that there's meaningful consultation, a qualities impact assessment, a human rights impact assessment, proper measures in terms of patient safety, and that the proposals really are delayed for that year. But on an Ealing level, can I also recommend that we as HASP have oversight of the approaches that our PCNs take to improving access? And crucially as well, I think we need to hear feedback from the early adopter site in Northolt. I will pause momentarily in case there are any other recommendations that colleagues want to have, but I'd ask for Councillor Crawford.
Oh, I welcome an invitation along the consultation process where members can actually go and observe to really see what the consultation, process is like.
Thank you. Yeah, I'm sure we can pick that up. NHS colleagues are very briefly.
Yeah, I just want to just clarify a couple of things around sort of the consultation versus engagement, because they've been used interchangeably this evening. So as Genevieve Small said in the meeting last week at the Civic Centre, we are absolutely committed to engagement with the public regarding improving access in Northwest London. That is absolutely a given. What we are saying is that we're not having a public consultation because this is a individual PCN bespoke approach in terms of how they want to improve access. So every PCN will self-determine what they want to do. You can't have a consultation on an individual bespoke approach that each PCN is going to undertake. So it's important that we have that public engagement, absolutely, at a Northwest London level. And in fact, we have a meeting with the public, a Northwest London engagement forum tomorrow evening, where the public are welcome and to hear and discuss and provide us feedback. We will continue that Northwest London approach. We need to continue that engagement at a borough level and also at an individual PCN level, which is absolutely paramount in terms of how we collectively work together to try and improve access. Ultimately, this is about improving the experience of patients and residents in terms of how they receive the care at their GP practice and collectively within their PCN. That's ultimately the goal, is what we're trying to do here. I just want to pick up the point around physicians association. I'm not here to defend or either agree or disagree about.
I'm not going to reopen the debate.
But that's fine.
Thank you.
Fine, okay.
So just to say, I think that people in Ealing would expect to be consulted in relation to what we are doing in Ealing, and the experience of engagement to date has been criticised by JOSC. So I would like us to move forward with a consultative approach, and I'm very happy to meet with NHS colleagues to talk about that further, because unfortunately we don't have time now to cover it. But I think it's really crucial that we take that approach moving forward so that Ealing residents, patients and the public are involved in designing those services in a proper manner. So thank you very much, everyone. Can I ask for the panel's endorsement for those recommendations? Thank you very much. So we now move on to the Ealing Safeguarding Adult Board's report, the annual report for 22-23. I know that some colleagues have to leave. I'd like to thank NHS colleagues and members of the London Medical Committee for your time this evening, and our patient representatives as well. I'm going to pass over to Robert McCulloch-Graham, the independent chair of Ealing Safeguarding Adults Partnership Board, to present the board's annual report. It's been created in consultation with contributions from our safeguarding partners in the borough. As colleagues know, we were supposed to take this item at the last meeting, but we have tested the sound, and unless there's any last minute blips, Robert, over to you.
Thanks very much, Chair. Can you hear me okay?
Certainly can. Thank you.
Right. It's been a bit with some trepidation here because I've been kicked out a couple of times. So fingers crossed that I'm going to stay here until the end of the session. So apologies if there are any glitches. Thank you very much for taking the item. And I know we had some problems back in December, so it's here now. Just to give you some background before I go into any detail, one of the issues I want to express is that I'm a fairly new chair. I started in June of last year. So the actual annual report is actually reporting on a time and a period of the partnership when I wasn't actually the chair. And my predecessor is Sheila Locke. And I've explained this in the introduction to the report. So there's a little bit of an anomaly here. So I am presenting on work that was undertaken when I wasn't actually the chair. Before I go any further forward, I wanted to give you some definitions and to give you a clearer explanation as to what the partnership is and why this report is here. So the Safeguarding Adults Partnership is here because of the Social Care Act of 2014, which makes it a statutory duty for every local authority to ensure that there is an independent partnership in place within their vicinity, within their region, within that. It's an independent partnership in that there are 3 statutory partners. The local authority and adult social care is one of those partners. The Met Police and the Borough Command Unit is a second partner. And the third partner is the ICB, our health colleagues within there. So there are 3 statutory partners who will fund the work of that partnership. There are further partners, including the trusts, including the voluntary sector, and including other agencies within Ealing who actually make up the whole of the partnership. Now, the reason for the partnership is to ensure that the citizens of Ealing are safeguarded by the partnership of services. And we are here to scrutinise the work that's undertaken collectively by that partnership and to ensure that the risk to vulnerable adults in Ealing is reduced as far as possible. That's the raison d'etre for the partnership. And there are 3 statutory duties that the partnership must take. One is it needs to have a strategic plan in place as to how we might reduce that risk and how we might assure ourselves that the partnership of services are performing well. And that strategic plan will then lead to a business plan for the work of the year. And the second duty then is to report on that work of the year, and that's our annual report, and that's the paper that's here. And that's a report which is agreed by the Safeguarding Adults Board itself, and it's here for information. And we also take it to other bodies within Ealing as well. The third statutory duty that we have is to respond to any serious incidents that occur with vulnerable adults, where we feel that the partnership may have been able to perform better and might have been to enable a better result for whatever that incident was. And you'll see within the report, there are 4 such safeguarding adult reviews that were commissioned in the time of this report for 22-23. And I may as well report on them now before going into the body of the report. The four safeguarding adult reviews, 2 have been concluded now, and they're written in the report. So they detail the Elsie SAR and the Owen SAR. Elsie was an elderly lady in a care home, a nursing home, where we felt there was some issues with the care that was provided. And that review resulted in some recommendations which have now been put in place within there. The other one was regarding Owen, which is a gentleman with learning disabilities who had a poor experience with one of our opticians. And again, that review is concluded and recommendations have been undertaken, and we've been in touch with the national body of optometrists as well as a result. There are 2 further SARs which have yet to be concluded. Now, they've been running for some time. One is the Miss B SAR, which is a lady who died who suffered from schizophrenia. That's due to conclude very shortly, definitely by the end of April. The second one is a more recent one, which was the unfortunate murder of a local resident, and that's been in the local press recently. And that has nearly concluded and will be concluded again by the end of April with that review. As I say, the recommendations in all of those reviews, which result in action plans for each of the services involved, and it's our duty to report on them whenever possible in the public arena and to include them in a report where possible. In some instances, it's not possible to publish because of the risk that's inherent to some of the families that may well be involved within those reports and for the ongoing issues of risk. So we do have to be careful in consideration how we might well publish that. So the report here is very much a reference document. Much of it remains the same for each year. It gives a description as to the duties of the board, its aims, its objectives, its principles, its values, and its vision. And the other aspect is reporting on the progress of the business plan. The statistics which are held within the plan, I have to say that this is probably a work in progress within this plan. It's heavily populated with data from the local authority. And in truth, this should actually be across the whole of the partnership. And this is a work in progress that we have initiated, and we will be addressing that. There are some other issues with how that's presented in this report. And as an ex-maths teacher, I do have some concerns about how that's actually presented here. And it is an issue that we would want to be taking up in the future. But in the main, if I can go to some of those points that are raised here, we have seen a slight increase in the number of inquiries, Section 42 inquiries. So we've seen an increase in concerns, an increase in inquiries. So concerns lead to inquiries. So they've gone up from 433 to 466. It's not a major rise, and so we're fairly constant within that. We also measure the number of concerns which lead to an inquiry. So when we have reports of cases coming into our services as a concern, we will then examine them, or the services will examine them, and then decide whether to move on to an inquiry. In 2022 to 23, the time of this report, 24.2% led to an inquiry, and 79% of them were completed within the year. Whereas the previous year, 21-22, there was 25.6 concerns led to an inquiry and 71% completed in the year. So there's not a massive difference between those percentages, so it's fairly consistent within there. One of the things we have reported, however, is the ongoing pressure across all services. And I think we've heard in earlier agenda items here that's shared with our health colleagues, it's shared with our police colleagues, and it's shared with local authority services as well. We've seen an increase in demand in services. That's also coupled with an increase in complexity. So we've seen a higher acuity of cases coming through, and all coupled at a time when we have financial challenges to face, and also for the general public, there's an economic crisis to be faced as well, which does seem to be hitting those most vulnerable within our communities. All services have raised this within our meetings, and it is something we're very conscious of, and one thing that we want to face when we're developing our strategic plan for the following year. So the plan itself then goes on to give you some indication of to the work of the partners, and we've included towards the rear of the report some short items from each of the statutory partners plus the two trusts represented there about their journey on safeguarding over the year of 22-23. And I've concluded in the report with saying our future work is looking to how we might enhance the partnership working that we have within Ealing. Sorry, excuse me. And one of those areas is to work much more closely with the communities. There is an existing piece of good practice which has been operating in Ealing for several years now, where we've involved a lot of the communities and services within the work of the partnership. And that's one area of which we want to enhance and to make sure that we hear the voice of the people and the voice of the service users, and that influences our practice. And that's going to be one of our focuses moving forward from here. I've done that at a bit of a canter going through the report, but I'll take some questions if there are any from the members of the committee.
Thank you very much, Robert. I can see Kerry is indicating, so I presume, Kerry, that's a comment, so I'll bring you in for that.
Thank you, Chair. Thank you, Robert. I think the point of note, which is really helpful, is that Robert, as the new chair of the Adults and the Children's Safeguarding Partnerships, brings a fresh look at how we produce these reports. And I think we've been running this report format for a number of years. And I think the opportunity for an ex-maths teacher, but also as a fresh pair of eyes to look at how we process issues in Ealing is really helpful. The previous chair was excellent, but sometimes it's good to bring a fresh pair of eyes to look at how we share information and gather that information and present it.
Thanks very much, Kerry. I'll move to questions. I have a number myself, but before I come in, I'll invite Councillor Conti.
Thank you. It was a really interesting report. I think one of the, I was just interested in some of the data about whether we think we're capturing all the data that we need to, or I guess, or the reports coming in from all the different communities. I just wonder, obviously you break down by ethnicity, by age, by gender, and I just wonder, are there any particular communities that we feel maybe we're not reaching, or that sort of safeguarding concerns maybe aren't coming in from? I just also noted when it comes to gender that in the sort of 1864, it was almost a 50-50 split in terms of men and women, whereas that gap sort of widened with the older the people got, and it was actually, proportionally many more women that were sort of having safeguarding reports. So I just wonder, in the older cohort, for example, are men being sort of less represented, for example, or is there actually a bigger problem as people get older in terms of sort of females when it comes to these safeguarding concerns? So it was just really about that data, and are there any communities or any groups in particular that maybe more work needs to be done to try and get or ensure that they're aware of safeguarding and how that can be reported?
Thank you, Robert.
I think sorry, Chair, do you want me to respond to each question?
Yeah, I'm happy for you to do so. Yeah, thank you.
Thank you. The important part, there's two issues around the data. Why do we look at the data? There's two reasons for that. One is looking at trends so that we can get ahead of the game and make sure that our services are actually able to react quickly to any changing trends coming up. And the other part is to ensure that our services are actually responding to that. So that's the scrutiny side to it. So there's two bits of the data we want to do. And from your point, it is important to know that across all of the communities within Ealing. And that's to do with race, ethnicity, it's to do with gender, it's to do with backgrounds. Anywhere there's a difference which might impact on safeguarding and any issues with that, we would be interested in making sure that we are alerted to that. And I'll go back to the point I was making earlier. Our reports in the past, and it's not just in Ealing, have heavily relied on the data and information coming from adult social care. What we'd be really interested in is information from the police, and they hold data around the number of adults or individual adults that come to their attention for numerous reasons, not just for criminality or anything of the law, but sometimes just out of care. And that's really interesting data that we would like to see coming into our planning groups within there. The other part is health, and if any of the health colleagues are remaining around the table here, health have a plethora of data, and far too much for us, actually. But what we need from our health colleagues is to be able to go in and interrogate those parts which are important to us, and around the safeguarding agenda. So we need to have a bit of a filter on that as well. If I give you a very quick example of some experience we're seeing within our younger generations just now, which will come through to adults. So a conversation I was having last week around mental health issues, where we have a number of cases within our 16 to 18 age range that are coming to the fore, particularly around gender-based issues and gender identity issues, which are manifesting themselves as a particular challenge for a cohort there. We see that as now at that age range coming through a number of reasons that we haven't identified, but will impact on our adult services because of the age range coming through, whether that's down to COVID, whether it's down to other reasons for that, but it is a concern within our children's services currently within that, and we know that's going to come through. So that's where our data and trend data is very important for us. And I think the point you make around the communities, that is, of course, important to us as well. The number of suicides that happen within the borough, there are particular cohorts where we've seen the numbers suddenly go up. And that trend data then forces us to have a question. Why is that the case? And where can we go and find the answer? And what's our response to it? Can we actually give greater protection to those communities where we're seeing those challenges coming in? So what we're trying to do for the next year is to make sure we're much more, not just data rich, but actually to be able to understand it and interrogate and get the narrative from the data so that we can actually plan our services collectively across the whole of the partnership. I hope that goes some way towards answering your question.
Thanks very much. Any other questions from panel members? Councillor Steed.
Thank you very much for the report. This is a very sort of general question. I mean, clearly you're working within the context of Ealing. Do you share information with your counterparts, say in Hounslow, or is there do you have access to a Greater London database, or where do you sort of fit within a national safeguarding, or do you not fit within a national safeguarding grid, if you see what I mean? Are you
Yes.
in isolation?
No, we're definitely not in isolation, but I have to say that there's quite a high degree of variance across each of the local authorities nationally. There are national bodies, so there is a national panel of safeguarding adults chairs, such as myself. So that's across the whole of the country. Also in London, there's a local panel that I attend on there, and they're very useful, and it gives me a bit of a heads up on what's happening nationally. That's also true of children's as well. Kerry has his London Association of Directors, as well as the National Association, and they're closely tied with the Safeguarding Adult Board chairs as well, as are the business managers, and they've got national groups too. So we're quite rich in the contacts we've got across the country. I think, if I was really honest though, I think we're not as good nationally about making sure that we're sharing enough information and data. I think we could be better at that. But it is a good avenue for a heads up of issues. We've had some significant issues around the use of international staff in some of our areas, where we've had some areas that's allowed us to have a bit of scrutiny here and how we're actually overseeing that and making sure that some of those issues that have raised their head in places elsewhere are not happening here, or at least we're given that sort of just a heads up, actually, so that we're warned of possible areas of safeguarding risk that are coming through.
Thank you. I think I saw Kerry indicating. Great.
Thank you. Just back to Councillor Conti's question with regards to disproportionality of men and women in older age groups. There is a disproportionality of men and women in the older age groups, and that's why you see a variation in terms of representation, in terms of safeguarding. In terms of the comparative data, we're certainly in the middle of preparing for CQC. CQC programme is being rolled out across Northwest London currently, and in the next 6 months, I estimate we'll have some good comparative reporting on CQC performance for local government in this space, as obviously safeguarding is a key aspect of the work that we do that we're measured by CQC on.
Lovely, thanks. So I'll go to Mr. Cook and then Councillor Crawford, and I'll take you one after the other, if that's okay.
Yeah, I'm looking forward to the future, that the reports that come from you, actually the data is a little bit better presented, because looking at the data currently, there are large holes in it, that things don't add up properly and there are things missing. So I'm just saying that I would look forward to the future.
Thank you, Mr. Cook, and Councillor Crawford.
Oh, thank you. I just want to ask, where are the carers in all this? I haven't seen anything about carers. And with regards to, you know, a lot of you know, kinds of abuse can take place in the home. Likewise, I think with, you know, family carers, try working with, you know, the older child and more physically abled, loads and loads of issues, and also doing their utmost to care for those their parents maybe with dementia. And I would just like, I hope that the this would carers would have been included, and the importance of having their reviews when they realise that the demands on them are quite high, particularly when they're getting to the point where they may not be able to manage. And those reviews are done in private. So, and also address, you know, they're the ones who can speak openly, honestly, about any issues within the family. So I'm just surprised that there's no nothing relating to carers. Thank you. Difficult
Chair,
one. Yeah.
Yeah, I'm happy for you to take those. So the first one was about the data, and then the issue of carers. But if we could have brief answers, because I've got some questions myself, and
okay.
After that.
Okay, so yes on both counts, actually. The data, I agree, and I think I alluded to that earlier on, actually. So yes, I do. And I think there's a misrepresentation in the sizes, just the presentation as well as the numbers, that we can do better. On the carers, but I am currently a carer myself. I've been a carer for my mum, and I'm caring for so my wife and I are caring for her mother now, both with Alzheimer's. So it's very close to home. Vital part of safeguarding, absolutely vital. That none of our services, Kerry's services, the health services, they would just collapse if we didn't have that army of unpaid carers that are actually doing the work that they're doing. So our direction across the partnership is to make sure that we give them every assistance so they can continue to be the carer that they are. Carer breakdown is a horrible thing for the carer. It's incredibly catastrophic for the person that they're actually caring for, and for the reaction on the services is very sudden. So it's in everyone's interest that we actually give every support to the carers, and I'd like to see it feature really strongly in the work that we do next year.
Thank you. I'll ask my questions, and I apologise in advance because there are quite a few, Robert, but that's perhaps because I sit on a strategic safeguarding group at the Nursing and Midwifery Council where I work. So it's an area that's really important to me. Firstly, in relation to the Safeguarding Adult Boards review, which you touched on, I'm interested to know how we are going. You mentioned the recommendations, but how we're actually embedding the learning that comes out of those, and then assuring ourselves that the same issues won't arise again. And appreciate that obviously you've taken over chairing this board very recently, but be good to get your thoughts on that. I'm also interested in how engaged our board members are, and if there are any barriers in particular to the delivery of their work. And then a couple of things in relation to the data. So the data very much focused on risk outcomes, but not kind of safeguarding personal outcomes. And I wondered if you actually record that information and what that information shows in terms of the kind of personal outcomes. And then I have a question. I told you there were quite a few. A question in relation to domestic abuse. It was one of the things that came out quite strongly in terms of partners' comments, and I wondered if the board intended to look at that moving forward. And obviously that links in with the engagement that you're hoping to achieve, I assume, from the police. And then I also picked up on psychological abuse. It's one of the highest referral reasons, but much lower in terms of making it to inquiry. And I'd just like to understand the reasons for that. So sorry, quite a few questions, but I think important issues for us to kind of get to grips with.
Okay, thanks, Chair. Right, I'll go through them in order then. So embedding the learning from our reviews is a bit of a national issue as well. So it's a question we continually ask. I think what's most disappointing is where we see a review which has been repeated of an older review, and when we had lessons learned, and then we're finding that hasn't changed. And so one of the things that we want to initiate is not just, once we get a bit of space really, is to look at the previous reviews that we've done over the past years and to see what that learning was embedded then. Is it still embedded? Now, staff change, workforces change, so there's a real drive for each of the services that are involved in any of those reviews, that they keep that learning fresh, and they're doing it. So that's part of our scrutiny, to go back in and actually do audits and actually see, is that still there? One of the most disturbing areas that I see time and time again is self-neglect, and the number of safeguarding adult reviews that have self-neglect as a theme. And it's a national issue as well as locally here, but it's the lessons learned and do we keep them there? So there are some perennial problems that we have around safeguarding, and particularly around assessing capacity within that. So it's key, and we will be challenging each of the services around their plans to implement the recommendations of the reviews. And we do want to go back to some previous reviews and make sure they're in place as well. Looking at the next one, struggling to read my writing. Engagement of.
It was in relation to it was in relation to how engaged our board members are, and if there's any barriers to their work.
Well, that's been the priority for me coming in as a new chair. As Kerry said, Sheila was excellent, and she was a real absolute powerhouse. Actually going through and doing it. And I think the drive that I've coming in myself is to make sure that the partners actually undertake a lot of the responsibility and accountability themselves within that, and so that it's proper partnership working that we're doing. And you can't do that unless you've got full engagement from doing it. So I think the priority I've had coming in is actually meeting as many of those partners as much as we possibly can, getting to know them on a personal basis, so that we can actually engage collectively around the board. People change as well, so we have new people in new positions, and so this is not a task that you just do once and leave. You're going to have to keep doing it. So I'm quite pleased with engagement so far and attendance. It's been good. So we just have to keep at it and don't let it drop off really. So that's a constant thing. I think that's all. And the data that we look at, it's a risk. We're risk focused at the present time. I'd agree with that. One of the areas I quite like, there's a question that we quite often ask elsewhere, the services ask this question, is if people feel safe themselves. Just a simple question. Do you feel safe? Are you concerned? Are you worried? Are you fearful? That type of information coming back and trying to get GPs to say it, police officers to say it, to ask it, social workers to ask it. We then get that richness of how that happens. And I've sat in some of Kerry's meetings around our external providers, so our nursing homes, care homes, and one of the areas that's always a concern for safeguarding is whether you've got a line of sight what's actually happening, because there's lots of people in these providers, and so I've satisfied myself through Kerry's work and those meetings around the quality that they ensure is there, and it's making sure that line of sight is there, and they look at proxy measures as well to see whether you can measure the quality there. So that's looking at the safety and safeguarding issues around there. So not all of it is held in data. Some of it is qualitative, but it's equally as important that you have that narrative. And also, it takes you back to the partnership and to the engagement in partnership. People need to feel, whilst they're challenged by the partnership, they need to feel safe and secure in the partnership as well, that they'll be supported, so that they feel free to raise issues and concerns that they've got, and that each of the partners feels free to challenge their fellow partners on there. And that's the culture that we're trying to make sure is inherent. And to date, I haven't got any qualms about that. I think everyone's felt very capable of actually challenging each other around that table. Domestic abuse, and we've had a number of domestic homicide reviews coming through currently from domestic abuse. One of the safeguarding adult reviews I just described as well had significant elements of domestic abuse within the history of there as well. We've seen an increase in that. The stats on it are a little bit not difficult to understand. We expected during lockdown to have a significant increase in domestic abuse coming through. We didn't see that happen. But what has happened since the lockdown has ceased, or since the pandemic is eased within there, it's coming to the fore now. So it's almost as if there's a lag within that presentation that we're seeing there. So there is an increase coming through nationally, that is, as well, and how we actually respond to that. Again, it's for me running the partnership. Domestic abuse is one of those issues which touches on every single partner. So our acute colleagues, our primary care colleagues, our police colleagues, social workers, schools in particular, and the reports they get back from the kids, it's actually making sure that there is a linkage between each of the partners, that we can get some early warnings from it so that we can see. And again, the stats are quite difficult, because in some sense you want to see more referrals, because it means the referrals are coming through. If these referrals reduce, perhaps it's a bit more worrying. It doesn't mean there's less domestic abuse going on, it just means we're getting less referrals. So there's a bit of catch-22 in that. And the last aspect, I think you were talking about psychological abuse.
Yes.
I think that manifests itself in several ways. It's quite difficult. I mean, the results of it are still the same in a way, that there is someone being abused at the end of it. The recognition of it is quite difficult, I think, and the identification of it is quite difficult. And therefore, I think a recording of it is probably not as accurate as it should be within there. And it is something perhaps I could have a further conversation with you actually around it, but it is a concern. The types of abuse have been changing over the last, particularly in the last 5 years. Things like economic abuse, financial abuse, the issue of cuckooing, where somebody takes over someone's home for illicit reasons. Those are new kinds of abuse that are coming to the fore. And it's almost like there's a bit of education going on with some of those perpetrators across the country, and they're picking up lessons of other ways of actually doing that. I've seen some very good work done by the police on high streets around banks and shops, and where they have early alerts that the police can be told of if there is a suspected financial abuse going on or cuckooing going on, that they will hold the perpetrator there in conversation whilst the police actually arrive. Some very good practice around that. But again, that's partnership work. Wouldn't happen unless people knew each other in those services. So that's a bit vague on the psychological abuse, I must admit. So maybe that's something I could go into a further conversation with you, Chair.
Thank you, Robert. Yeah, I would definitely welcome a further conversation about that, and anything that we can do as a panel to sort of raise visibility and educate the general population. Very happy to be involved. I'm not seeing any indications from panel members. So I think all that leaves me to do is to thank you for that report. We've noted it. We look forward to receiving the annual report next year with the data that you mentioned, which I'm sure will be much improved with your knowledge of mathematics. So thank you very much for that.
Okay. Thanks very much indeed.
Most definitely. So we now move on to the item on social care and community choice. We are about, I think, 20 minutes behind schedule. Kerry is known for his brevity in introducing reports. We'll hear from Kerry, and then we'll open it up to the panel. Just by way of context, the report provides an update on the review that's been undertaken to promote the council plan priority under Healthy Lives, and that's for people to have control over how money is used to meet their social care needs. And we're being asked to consider the report and then make any recommendations. So I'll pass over to you, Kerry.
Thank you, Chair. This is a key part of our approach to work within adult social care in terms of promoting independence, creating communities, community resilience, and responding to the inequalities that exist within the communities in Ealing. Direct payments provide individuals with choice and control over how their needs are met within the community, enables them to look to people within their neighbourhood to support them, and allows people to have greater influence to commission and procure services that reflect their personal, cultural, individual needs. We see this as a real strength of direction of travel for us. We recognise that in adult social care, our performance in Ealing has been poor in this space, so it's going to be a significant focus for us going forward. I think it's relevant to have this item following Robert's presentation on safeguarding, because there is risk associated with this approach, and there's some of the mitigations to the risks that come from promoting choice and control within the direct payments model. So bringing the paper here for information and for question and influence in terms of our direction of travel, Chair, because this is something that we're wholly committed to within the council and within the service, but any feedback and commentary in terms of our direction of travel will be hugely appreciated. So thank you.
Lovely, thanks very much. And just to assure everyone, I don't have 5 questions on this item. Councillors and panel members, comments and questions. Councillor Conti.
I had one question, but it may be my ignorance. In the report, it says that the council recoup about 1.2 million of unspent money, but it also says that care agencies charge more for self-funders, and they charge at a higher rate for care. So how do they end up with money left over if they're spending more, if they're being charged more to start with? I wasn't sure how that all made sense.
I'll respond to Chair. Thank you. Thank you, Councillor Conti. It's a really good question. So there's a number of aspects at play within the direct payments model. People with a direct payment can pay people within their community. So I could pay my neighbour, Anna, for instance, to support me with certain tasks within the home, which wouldn't be going through a traditional provision through a domiciliary care or a registered provider. So there's opportunities there in terms of reducing costs and improving people's community resilience. There's also something in terms of the when people receive direct payments, they treat it as their money. It is their money, it's to meet their needs, and people tend to be better at promoting their own independence, and that's how we recoup the money. So the investment that goes in, the 1.2 million, is unused funds at the end of each financial year, which we then claw back. Individuals are still meeting their needs. They're meeting their needs in a more cost-effective way, but also in a way that better promotes their independence and engagements with local people. So in effect, Not everybody uses registered providers because they'll use support within their community, but people tend to do more for themselves, and in line with our Better Lives methodology, it supports people to be more independent and to meet their needs more effectively.
Mr. Cook.
Yes. You're talking here about 300 adults with direct payments. Is there any particular reason why we are so low compared to other places? And is this the same process that was introduced back in 2010, 2013, the direct payments? Because if that was so, in 10 years, we don't seem to have got that many clients in that direction, moving in that direction. I just wondered, some comment, please.
Thank you, Mr. Cook. The reason why we're lagging behind is because we haven't had a focus in this area. It's something that we're rectifying now. We've been focused and supporting people to live independent lives as possible. And we see the promotion of direct payments as the next iteration of that model. So our methodology and our approach is changing from better lives to connected communities and better lives. So we see the reablement and the connected communities to be better aligned. I've completely forgotten the second part of your question now. I do apologise.
It was about, is this the same methodology as was introduced back in 2010, 2013? Because I can remember you coming to Link, which was a predecessor to Health Watch, and talking about it. Not you personally, but...
So I was just doing the maths in my head, and that's probably what's thrown me. Direct payments has been around for at least 16 years, at least. So I'm just trying to work out where I was when I was first implementing direct payments. So it may be that Ealing came slightly late to the implementation program. I can dig that information out. I've got colleagues who were around in 2013 who will be able to confirm that position.
Thank you very much. I just wanted to ask Kerry, in terms of what we feel that any thoughts from yourself in terms of what increasing direct payments might do to the market and what we've seen happening elsewhere, because I know that you're obviously linked in with colleagues in different local authorities.
It's part of the risk in terms of the mitigations that we've included within the report. Ealing's domiciliary care market is one of the most dynamic in London. We've got bottom quartile in terms of cost, top quartile in terms of quality. So we've got a very vibrant, active market in the borough, which is really positive. We see that the initial move to direct payments shouldn't have significant impact, but it's something that we'll be working very closely with. We will continue to only procure services from good and outstanding home care providers, but within a direct payments model, you can't put those constraints on individuals.
Thanks very much. Even Sarah, I'm not sure if you realise you're not whispering as quietly as you think. So just wanted to point that out. Other councillors and panel members, any comments? Councillor Crawford.
I'd just like to ask about on page 75, it states that direct payments can be hard to manage, and the council is improving the support it provides for this. So with our young people, when we know that they're going to go, you know, they have the opportunity to take on direct payments, what work is done to support them, to advise them, and you know, going back to carers again, and because I have a feeling that, well, I know that some carers feel that the burden is being, you know, on them, and they perhaps don't feel that they have the support. So the young person might want the direct payments, but you know, the older person who perhaps, you know, isn't able to manage things as well. And the second thing is to me, if you're going to have direct payments, and I'm all for people going, instead of going to day centres and and whatever, they actually use local support. So this needs to encourage direct payments, surely. Well, I'd like to know if any working is done, partnership working is done, for example, with the arts, and where there's funding, small pots of funding to create services that people might want to take up, as opposed to doing the regular thing of going to a day centre, which can be a bit institutional.
Thank you, Councillor Crawford. Lots of really important questions there. In terms of working with younger people as they transition into adulthood, we've got a really progressive programme of work that's been in place for a number of years in Ealing, where adult social care workers are working with young people and their families from the age of 14 upwards to prepare them for the additional opportunities of independence, and direct payments will become part of that programme. So for the young people and their carers to understand the opportunities of direct payments, it's a really strong model, and we look to build upon that. In terms of carers, and I think the chair mentioned earlier, and also Robert did, in terms of the importance of the role of carers in the community in Ealing. This year we've given over 600, I think we're just over 600 now, one-off payments to carers to support them in their role. It's not a huge amount of money, but it's an amount of money that we think will support them in terms of their caring function. We encourage people to complete carers assessments, but we see that opportunity as a one-off direct payment for carers may enable people to ease their role as a carer, to buy a new washing machine, to buy whatever is going to support them in their role, and we've got no constraints on that. I think your point with regard to day centres and various services, the huge opportunity with direct payments, and I think this is discussed within the report, is developing micro enterprises and micro responses that are available to the local community. We currently transport people around the borough to a small number of day centres. Some people are on the bus for quite a long time, and that's not good in terms of how they spend their day. Their services, their needs aren't being met in their local community. They're not with people from their local community, and it's not reflective of their local community. So our aim through our Ealing Direct service, who are the support service for people using direct payments, will be to create more local services, more responsive services, because as a monolithic organisation with institutionalised responses, we can never meet the wide and diverse and vibrant needs of the communities that we serve in Ealing. So this is a real opportunity.
Thanks, Kerry. Councillor Nagpal, you have the final bite of the cherry on this one.
Thank you. So you mentioned it as a response to one of the previous questions, that people can use these funds sort of, to offer it to a neighbour for some support, or a friend, or what have you. If a neighbour is receiving that funding or monies, do they need to declare that as a form of income anywhere? And have you seen abuse of the system? The neighbour knows that they can have access to this money, and yeah.
Kerry, thanks.
Is that okay to respond?
Yeah, please.
Another very good question, and thank you for that, councillor. If people are being paid, they need to declare that money, and that needs to go through HMRC and the various routes that people do declare where they're receiving an income. There is risk within the direct payments model that people will use the funds inappropriately, that there's risk to them in terms of people in the community taking advantage of them, and the funds being misappropriated on that basis. We work very closely with our internal audit department to ensure that council monies are managed effectively, and we've got a number of and a range of mitigations in place to ensure that where people are using funds within the local community that we're discharging our statutory duties in terms of meeting eligible need, but also that people are using those funds appropriately and declaring them. There are a number of cases every year where we're taking people to court for misappropriation of this money, and it's important that we keep that up, but that should not prevent us from changing how we support people to have choice and control over their lives. But it's absolutely right, and it's something that's up very front and centre for us in terms of our response.
You happy with that, Councillor Nagpal? Great. So Kerry, thanks very much for the report. We note it. We wish you well with the work to increase direct payments, and look forward to hearing about how those plans progress. And I know you'll come back to Mr. Cook in relation to his request about when they were first introduced in the Ealing context. That'd be super. Thank you very much. So item 10, last but no means least, I'm going to invite Anna Bryden, our Director of Public Health, to present the Health of the Borough report. This sets out the council's achievements during 23-24 to tackle inequalities across the borough, and it shows how multiple council departments are helping to achieve the council plans. So I will invite Anna to present the report, and then we'll take questions from panel members after that. Thanks.
Thank you, Chair. So you've already introduced some of it. Thank you, Councillor Wesson. So this is the draft for input from this committee. It's the second year of this report. It was something new that the council started last year. Just to clarify, this is council only report, not to take away from all the wonderful partnership work we do with lots and lots of organisations in Ealing, but this was felt there's so many departments in the council that contribute to improving wellbeing and reducing inequalities, and we don't necessarily talk about it and we don't share it. Every year we've done this, the surprises for me in this report of things that are happening across the other departments that I think are fantastic, and we don't always link them up. So this is really to kind of showcase some of that and really think about those kind of building blocks of health that really impact on inequalities in our borough in terms of education, housing, employment, etc., that are really important to us. One thing I did want to mention at the start at last year's Scrutiny Committee, we did talk about a kind of idea about inequalities dashboard, looking at trends, thinking of so the first few pages that are looking at the inequalities information, we did talk about how could we make that into something a bit more active, interactive, a little bit more looking across time. Just to say, under the actions under the health and wellbeing strategy, we are working across our borough-based partnership with our NHS and CVS colleagues, developing that at the moment as a broader thing. So it is separate from this report, but it is in development, and hopefully by summer we'll have something we can share around that. Just a few highlights, I suppose. There's really fantastic examples in here. I think a lot of panel members will be aware that the council, along with community and academic colleagues, have been successful in bidding for £5 million of funding to set up essentially a research infrastructure. So really learning together how we promote more healthy, thriving and equitable communities. And I think that will really push some of this work forward as well, really support us going forward. There's been great examples of real, going back to what Vijay was saying about engagement consultation, real co-production of a suicide and self-harm action plan, an awful lot of community voluntary faith organisations, but also individuals with lived experience. So really good examples there. There's been great examples in terms of some of the environment work. So, for example, community worked with Let's Go Southall, really having kind of trusted conversations with local community members, lots of different languages, lots of different ways of engaging around active travel. So that was a really good model. There's a lot of work happening across education in terms of race equality, massive agenda. You can really see the commitment there across all of the schools and all of the education settings to really drive that work forward. And finally, just quite a few nice examples in terms of cost of living. So really thinking about how the council's refurbishing, giving out laptops, especially in terms of people in really vulnerable communities, community hubs in libraries, giving out mobile data packs, etc. So I think just some really nice things in there, but really keen for the panel to feedback any thoughts about this. We are going to look next year about how we do this work. The first year we wrote this, we didn't yet have the health and wellbeing strategy, and there's work that we're doing every year to gather case studies under that. So there might be an element of duplication for this particular year, but we're going to look at how we neaten that up going forward. But yeah, really just over to the panel, and really grateful for any comments. Thank you.
Thanks very much. Anna, can I say before opening to panel members for questions, I just want to thank you and the team, because it's really clear that a huge amount of work goes into producing this report. There's some really fantastic initiatives. I really enjoyed reading through the case studies. I'm really excited about the research initiative in particular, and I think that you know, that's really positive for us to be engaged with. And obviously you referenced the Let's Go Southall initiative, which is also brilliant too. My question would be, I know that last year we had a conversation about performance metrics, and we've discussed outside of the committee that it's difficult to kind of shift the dial on some of those things, not least because the impact isn't necessarily immediate and can kind of happen over time. But I just wondered if you had any thoughts about maybe a standardized way that we could report impact year on year, just so that we might be able to see some of those trends over, if this is a regular fixture in our kind of suite of reports, whether we could see any sort of trends. So be really interested to get your views on that, and open it up to any other questions from colleagues. Or maybe if you deal with that one, and then we will come back.
Yeah, happy to. Thanks, Chair. So I think it's something we've we cover. We showcase the data trends in lots of different ways already. So we've got our Joint Strategic Needs Assessment website. There's a Ealing data website, which we're trying to promote. We've done reports on 7 towns. So I think that's why we've, as we were developing this, it became a bigger piece of work. And I think it's really important that that isn't just council information. We are doing that across our borough-based partnership. I think it's also thinking about how that's made, you know, going back to the safeguarding report, how it's made accessible, how it's made interactive. So it's not just a standalone thing. I think we are thinking about under that, what are the kind of projects we could get out of that. So actually, whether it's in this, whether it's in my annual public health report, however it's done as part of the JSNA, that we take a kind of snapshot and we pull out the key trends from that year. So that is underway, but it needs to be something bigger to make it meaningful. And we've got lots of, we're not starting from scratch with this, but I'm really looking forward to seeing that how that evolves over the spring.
That's lovely. David, you had a question, and then I'll go to Councillor Crawford after that.
Yes, Anna, thank you. So there's one statistic that really jumped out to me just as a former educator, was the school lunches statistic, the increase in students who are eligible for school lunch. I know there's a program in place where every student is getting free lunches in Ealing, but my question was, do you know if these students are getting meals on weekends or over school holidays? Is there a program in place for that? Forgive my ignorance if there already is. Okay, thank you.
Thanks. I'll take Councillor Crawford, and then Anna, if you come back on all of the questions in one go, that'd be great.
Hi, I'm interested in what we're trying to do in meeting the needs of the homeless. Every councillor in there has the casework, and it's horrific, really. And we are seeing people, you know, families in very small, you know, mother and child, you know, mother and son can be in one small room. And I'm interested in knowing what work is being done to keep tabs, particularly on those young people who often, you know, particularly when they're going through puberty and they're, you know, gearing up for their GCSEs, A levels. They don't and they must not leave their schools. So that they can be housed elsewhere as well. So what work is being done to, you know, work with the schools, the head teachers, in understanding, and actually, so the housing support, sometimes they might be able to find something which is really pertinent, and they do need to be moved and supported, you know, closer to where they are at school. It's, you know, because often I find that head teachers, they might do a report, but they haven't got the real information that is needed to get housing to address the needs. Thank you.
Thanks, Anna. Appreciate the two very varied questions, one about school lunches and the other about sort of homelessness. And I do also appreciate that this is about bringing together lots of sources of information. So if you can provide answers, then do. If not, we can get the information afterwards.
Thank you, Chair. I was just going to suggest that. So there's a few things I can definitely answer, but on behalf of lots of partnership work, and there's a couple of very specific queries in there I'll bring back, if that's okay, from other colleagues, especially from my education colleagues. So school lunches, absolutely in terms of that increase in eligibility, I think we're seeing that through COVID, we've seen that through the cost of living impacting a lot of areas. There is a service that works across a holiday provision in terms of both activities, free school meals, vouchers, etc. And I think that is one of the case studies in here, but I can definitely go back and get more information on that. There are some London work around free school meals and increasing that and making it universal. Really interesting to see kind of what are the inequalities impacts on that. I think one thing we're finding across London with that's coming out from some of the analysis, so not Ealing specific, is around the fact that even previously, if people and families were eligible for free school meals, they weren't taking them up. That might be, there might be cultural aspects to that, there might be stigma aspects to that, lots of things, and actually making it universal evens it out. So actually people who were eligible before who weren't taking it up are now. So I think that's a real positive, but I can definitely bring back some more information on that, especially around holidays, because I appreciate that's a real challenge for families. Homelessness, Councillor Crawford, there's lots of work going on, and we're only a small part. I think with Neha and colleagues, we've recently set up a homeless health board, which has a lot of different partners in it, really to think about the kind of health aspects of that. We've had our strategic director coming in a few months ago, and she's really driving some of this work as well. Absolutely appreciate this is massive, long-term, complex issues, and we touch on it in so many ways, and especially from my point of view, from a kind of prevention angle. We've had work specifically done with our substance misuse service and around Southall with a lot of voluntary sector and faith colleagues as well, and really with that overlap in terms of the wider health of residents with substance misuse issues, in terms of how does somebody look after their diabetes if they're homeless and don't have access to to housing and a fridge and things like that. And really thinking about how we can work together across the partnership. In the health and wellbeing strategy, we specifically pulled out homelessness, saying let's look at this as a whole systems issue. And I think there is definitely work over the last year that feels like it's moving in that direction, but it's not quick. In terms of young people and education, that is something I'll come back to. I'll speak to colleagues about to kind of provide that, because I think it's a really important part, that continuity. Not just keeping the people in education, but also the relationships they've had, the trust that they've had with people at those schools, I think really important. So I'll come back to you on that if that's okay in overwriting. Thank you.
Lovely. Any more for any more at this rate? Oh, Mr. Cook.
Thank you. What concerns me is that Ealing appears to have the highest alcohol-related hospital admissions. Now, there may be something in the report that does say what you intend to do to try and bring that down, but having such a long report, and it may only be a small bit. So I wonder what the plan is, because this is having a large impact on the NHS services that are provided, both at primary care level and at secondary care. I just wondered, and is there a cause for these particular areas? I do notice that in a previous report, Northolt Mandeville was actually not as bad as it appears to be now. And yet a couple of the others that were bad, Acton Central and Acton South, seem to have improved a bit because they're not mentioned.
Anna, are you able to comment on that?
partly. So I will come back to you. So substance misuse sits within my team. There is some information in here. We did do joint strategic needs assessment over this last year from a substance misuse point of view, and that's going to Health and Wellbeing Board tomorrow. So there is, it's something that's not new. It's a long-standing issue. We are going to, over the next few months, develop a mini strategy action plan. We have set up a new combating drugs and alcohol partnership board that's got senior buy-in from an awful lot of colleagues, including health, police, etc. And that's really helping hold some of these longer term issues, I think. We've also been very fortunate. There's been quite a bit of funding coming from national government over the last year in terms of delivering on their drug strategy, and a lot of joint working with health on this. But in terms of the alcohol specific parts of the service, if you're happy, I'll come back to you with a few briefing points in terms of what the service currently does and for the next steps.
That'd be lovely. Thank you. So final bite of the cherry, Councillor Conti.
I was just sort of follow up on that really about how that fits in with licensing. So is there sort of discussions between sort of public health and licensing in terms of those, the particular, in particular in wards where there is a specific problem, about how those two things feed together?
Anna.
Thank you, Councillor Conti. I think there is partnership work and going there. And again, referring to tomorrow's meeting, the Health and Wellbeing Board, we have actually put in some additional public health funding into a partnership work with our licensing team to set up some alcohol partnership work, which does have that focus on where people have concerns in local areas and local communities about specific sites. And so kind of doing the more proactive engagement side of regulatory services rather than the really reactive side. Some of that will be linking with schools as well in terms of education and developing that through there and with one of our local voluntary sector organisations as well. So I can share that paper through Anna Marie and we can see that. So there is a relationship there, and the funding that's just been agreed, I think will really push that forward. It's just for a couple of years, it's non-recurrent funding, but it will help us set up a bit of an infrastructure and some of the shared data and things like that to really kind of push that forward. I think it's also one of those parts of the council that has been under pressure for a number of years, and so we are working with them in terms of the public health grant. What do we use that for across the council, and how is that supporting that work?
And I think just to add to that, we might well take it as a work programme item for next year, so that we could look at it in a bit more detail. So thank you, Anna, and thanks also to Dr. Maddie Gupta Wright in your team for the work that she's done in pulling all of this together. And please relay our thanks to her, and be really grateful if you could follow up with the panel members on the specific bits of information. That leaves us then just with one final item, which is the date of the next meeting. The date of the next meeting is the 16th of May. I can't promise that it's going to be any shorter than tonight's, because we do have a number of items to discuss, and a number indeed. But before that, we have a briefing on the care line, and we also have the sexual health service visit. So just reminders about those. And finally, just to say thank you, everyone, for persevering with what was a long meeting. Thanks to all the colleagues that have supported with reports, and hope you have a good rest of the week. Thank you.
Chair.